Okay, good afternoon, everybody. I think we're going to start here. Thanks so much for coming to today's event, Public Health Management After Natural Disasters, Preparation, Response, and Recovery. My name is Gib Clark. I'm the coordinator of the Global Health Initiative and program associate with the Environmental Change Security Program, the two programs that are putting on today's event. Apologies to those of you who have heard this before, but if you're new to the Wilson Center, let me just give you a quick intro. The Wilson Center was founded in 1968 by an act of Congress establishing a living memorial, quote unquote, to President Wilson, as he was our only president to have earned a PhD, for better or for worse. The Wilson Center aims to bring together the worlds of ideas and the world of policy. The Global Health Initiative was formed at the Wilson Center in response to the fact that nearly all of our programs here were looking at health in one way or another. And so in addition to serving as a clearinghouse for the health work, we also focus on health's impact on development, the role of international and national institutions in global health policy, infectious diseases, and emerging health technologies. We're pleased to be co-sponsoring this event with our Environmental Change and Security Program, as I said. The ECSP has looked at these issues also a lot in the past, including in 2006 in a series where we looked at conflict, health, population, and fragile states, and that included a presentation by Skip Burkle. We have three outstanding health experts with us today. I won't go through all of their biographical information. That's all available outside and would eat up a lot of our time here. But I will just say quickly, Eric Noji is a physician trained in emergency medicine, epidemiology, and tropical diseases. He retired just a few months ago after 20 years at the CDC, where he was assigned to WHO's Department of Health Action and Crisis as the Director of Global Health Intelligence for Emergencies. He is now the chairman of NGH&S LLC, a company that provides clinical public health and information management services to private and public sector organizations involved in disaster management and humanitarian assistance. We'll next hear from Skip Burkle. He is now, just for the summer, serving as a public policy scholar here at the Wilson Center, so we're thrilled to have him here at the center and here to present today. He is a senior fellow at the Harvard Humanitarian Initiative and an associate and research scientist at the Center for Refugee and Disaster Response at Johns Hopkins. He is also a clinical professor of surgery and adjunct professor in tropical medicine at the University of Hawaii. Finally, we'll hear from Lynn Lawry, who is a specialist in internal medicine, disaster research, and epidemiology. She is currently at the International Health Division within the Office of the Assistant Secretary of Defense for Health Affairs. She is also the director of the Initiative on Global Women's Health in the Division of Women's Health at Brigham and Women's Hospital, and director of research and education at this Center for Disaster and Humanitarian Assistance Medicine of the Uniformed Services University. I could go on and on, but I think I'll stop there with the intros. One last thing to say before we get started. We are webcasting this event, although not live. It will be posted within about a week or so online. So when it comes to question and answer, please wait for one of my colleagues to bring a microphone around so that people watching virtually will know who you are. So with that, look forward to today's presentation. Thanks again for coming, and we'll start with Dr. Noji.
Thank you very much, Gib. Delighted to be here, and particularly since the topic of my discussion, the historical development of public health responses to disasters, just in this audience, you can see the historical development of my career. I'd like to acknowledge Mr. Leo Bosner from FEMA. The very, very first meeting I ever went to in my life on disasters, March 6, 1985, was convened by Leo at FEMA and was addressing the poor transfer of information from academia to users in the field. What's changed? And then we have Dr. Skip Burkle, mentor for many, many years, and Dr. Lynn Lawry, who's an example of everything we strive for in the academic study of disasters that will hopefully improve future response. What I'm going to do is give an introduction which will lead into the presentations of the other two speakers, but when I think of the timeliness of this event, it couldn't have been more timely in terms of natural disasters. We were planning this in April and May, and just in the last month, we've had three of the most catastrophic natural disasters in the 20th century. Cyclone in Burma, excess of 150,000 deaths, earthquake in China, and then this event in Iowa, probably 100 to 500 year flood. So it's certainly very timely and in the news right now. So the agenda that we will be discussing this afternoon, I'll be focusing more on the development that led to the current state of disaster relief and humanitarian assistance and health care reconstruction. At first, I was focusing primarily internationally, but in the event of Katrina and now the flood, I'll make some comments on domestic disasters and then outline priorities for the future. Basing this lecture historically on a series primarily in epidemiologic reviews, which are, I'd highly recommend reading these because they summarize the thinking at that time, and you'll see the change from famine, relief and food, to natural disasters, to complex humanitarian emergencies. Michel Lechat updated the 1981 publication in 1990, and it was soon after the Mexico City earthquake, so very much natural disaster oriented. Michel Lechat, founder of the first disaster epidemiological research center, which is still going pretty strong. Felt we had to do another report in the mid-90s because in 1990 it was before the breakup of the Soviet Union and the unleashing of incredible political, economic, social, and violent conflict. And so I got a partner, Dr. Michael Toole, probably the most famous person in the field of refugee, and updated once again in last year in epidemiologic reviews because the previous one didn't cover the World Trade Center and all of the disasters in the event of, there's nothing on bioterrorism, for example. So not surprisingly, disasters have been a problem since antiquity, aren't going away. But I've turning my attention now from in my career from very practical issues of food, communicable disease control, nutrition, maternal child health, rapid damage assessment, to more global issues of factors contributing to disasters. And this is, I think, where we merge into the public policy field, health policy, and even foreign affairs and foreign policy. And so I think that's great that we have this session here at the Woodrow Wilson Center. But each of these can be covered by a course at a university in themselves. Of course, poverty and social inequality, who's mostly killed by disasters, the poor, disenfranchised. They tend to live in the areas of environmental degradation, and unfortunately, rapid population growth, especially among those populations most at risk. There are many aspects of disasters, but being an epidemiologist, I'm going to focus on one area, health information needs in emergency populations. I just can't discuss communicable disease control, nutrition, vaccination programs, environmental sanitation, and then water issues. Those are tremendously complex issues. So at CDC, our major focus was establishing healthcare priorities, ensuring targeting of resources by collecting information. And pretty much, this might seem, common sense right now, but just 15, 20 years ago, it was very, very difficult to convince the decision makers who controlled transportation, communications, that there was a role for public health and data collection in a disaster. I can remember spending days just trying to convince a National Guard general to allow us to even enter a disaster-affected area. Specific example, that was Hurricane Hugo, and in 1992, Hurricane Andrew. Then they thought we were doing research. They equated data collection and trying to convince them that our data was specifically operational, that it would allow them to improve their decision making. And then you have to be P.T. Barnum. If you make wrong decisions, it's going to look bad in the press, and you might have some problems, lose your job, et cetera, and that usually worked. But Bill Foege, probably our most respected director at the CDC, really summarizes very nicely. The reason for collecting, analyzing, and disseminating information on a disease is to control that disease. Very practical. Collection and analysis should not be allowed to consume resources if action doesn't follow. So the mantra, which is ingrained into our brains our very first day at CDC, is data for decision making, which at that time was a rather novel idea, because epidemiology had been primarily a tool used by academicians. We go through time, and a nightmare for us at CDC was how do you make decisions with no data? And the classic example of that was the anthrax crisis in the fall of 2001, following the World Trade Center. Having to make decisions in the absence of data. No real experts in weaponized anthrax, although there was a string, like an assembly line of quote experts on CNN and all the major networks. And a lot of CDC's work since then has been, we have to develop a coherent, rapid process for addressing scientific issues in the midst of a crisis. I have to say that we did not do a good job in taking our information or lack of information and communicating that to the public. Do you know that in 50 years, and that was our 50th anniversary, 2001, we had never given a large-scale press conference, like as you see at the White House, where you have a press corps. And this is despite our major role in polio, smallpox eradication, West Nile virus, et cetera. None of us got training in interacting with TV and the written press. And we said really the stupid things like no comment, or in the absence of information, it's myths, rumors. They go like wildfire. Sometimes wrong information is better than no information. Poor performance by all of us, including myself, and then the political issues, which have been a major part of every single disaster I've been in, about 82 disasters. I don't know how to address that issue, but this is a typical day at CDC in autumn 2001, going to work, and mostly it was a pile about up to the ceiling of return a call to CNN, BBC, ABC, New York Times, Washington Post. And when you see articles like this, they certainly became a major political issue, and were probably the major cause that our director, one of our most popular directors, lost his job. With all the advances, though, through time, and use of handheld technology, internet, the bottom line is we still have to do ground surveys. And at this time, it was pretty bad because we were still using paper. This is a Bangladesh cyclone in 1991. It had to be hand entered into a computer, and the person who doesn't know anything then has to analyze that data. And of course, computers weren't that sophisticated then, and unfortunately, I never heard the word backup in those early days. But just go through this quickly. CDC now, we finally entered the modern age, data collection using handhelds, immediate collecting them at the end of the day, and then the team would just infrared it into one handheld by the team leader. This is an example of the acute disease. And then with the tremendous advances in telecommunications, et cetera, we can now quickly communicate that information to decision makers at the very, very highest levels. Now, what's also good to see is more and more documentation of these advances. I reviewed I was at the National Library of Medicine, and the number of publications in disasters this year was about 5 times greater than just 9 years ago. And Dave Bratt, a very fine field disaster responder, summarized rapid epidemiologic assessment in displaced populations. I won't go through these, but it's very, very, because I know Katrina will be discussed, but very depressing because these recommendations followed Hurricane Andrew, Hurricane Hugo, the Mexico City earthquake, reorganization of government. This was the time that FEMA had been pulled from an independent agency into the new Department of Homeland Security. Of course, need interdisciplinary research. When you think about it, only very few people have done that. Physicians working with engineers, are working with social scientists. Roger Glass, who's now the director of the Fogarty Center at NIH, his studies have still not been equaled from 1976 Guatemala earthquake and a tornado in Texas. And then, of course, the bottom one, so that we at the federal government could spend more money, centers of excellence. When I was overseeing the centers of excellence at CDC before 9/11, we had 3. Last time I checked, I think CDC is funding about 175. And I lost track when I was trying to do an epidemiologic curve of the number of universities and institutions of higher learning, which are now CDC-funded academic centers for emergency preparedness. It's everything from I think a high school up to Harvard. Well, actually, a better example would be maybe Stanford, because I went there. And we see a lot more. You know that a field has arrived because early in my career I was told that I had no future in academic medicine by choosing a field with no distinct body of knowledge, that it was a mismatch of other specialties, and that I better look for a job seeing patients at a urgent care center. This was at Johns Hopkins, and I won't name names, but it was the dean of research at that time. And now we have the AMA, the very heart of organized medicine, with its own journal, which has been approved for indexing by the National Library of Medicine, which means it's accessible by a PubMed or Medline faster than any other journal in history. We now have, but the history of centers of research is not really new. This is the classic one, 1972, which was the force that led to this one was the Nigerian Civil War and the tremendous human tragedy in Biafra. Most of you are probably too young to remember that. Like me, I wasn't even born yet. And the guy on the right is probably the founder of epidemiology of research, Lisha. The gentleman at the right, I don't know if he's here, Claude DeVille, former director of disasters at PAHO, took that knowledge when he was at the Center for Research for the Epidemiology of Disasters, and probably has done more than any other individual in translating research into education, into dissemination to developing countries. And his focus was, once again, he took one topic, one thing at a time, did it very well, did it on time, and moved on. And I've taken that as kind of my career type activities because you just have a difficult time multitasking. But he took supply management. You had situations like this in the 70s and 80s. He spent a lot of time developing. This is one of the key hallmarks in the development of disasters. Simply, I guess, doing an inventory of drugs, supplies, and equipment flowing into a country because there was no way of accounting for what was coming in. And we've had more developments now, accountability and standards. And this is a project that started by NGOs and major agencies in the UN system, WHO, UNICEF, UNHCR, ICRC, Federation of the Red Cross, humanitarian charter and minimum standards in disaster response. But what's kind of depressing to me is these myths don't die. And when very distinguished physicians in helicopter fly over Sri Lanka and Burma and say that there's going to be epidemics breaking out of diseases which have never been seen in that area, ever. I don't like to mention names, but one of them is a physician for CNN, and another one's very well known, or was, politician in the Senate, but I don't like to name names. So despite these tremendous advances, documentation, who reads them? And in many of the, you assume everybody, because in our very small professional community, everyone knows these studies, but the vast majority of operational people in health, medical response, since there's no professional opportunities, mostly are volunteer, pay is very low, or they're no pay at all, very admirable, but there's no institutional memory. And these recommendations and simply wrong statements are perpetuated again and again. And we're seeing it again in Iowa, which in 1993 had not quite as severe flood, but it was that summer where half of the Midwest was underwater, summer of 1993. But, when the public sees that, we've had to write. This is an excellent recent article on infectious disease risk from dead bodies, of which there is very little risk, but PAHO has come up with many, many excellent summaries of literature from forensic medicine. I don't know how many of these I've read. This is from ICRC. But these things can cause problems, big problems, because wrong decisions lead to decisions and lead to allocation of resources, and this diverting of resources can kill people. And I don't know what to do about it. It's something that has been a problem my whole career, and I've run out of ideas. Once again, myth too tough to die. And then communicable diseases and complex emergencies, different problem. It is a big problem. Epidemics after natural disasters. This is where I got kind of into trouble because I spent a lot of time saying that there were little chance of epidemics after a natural disaster, unlike a refugee crisis. But Watson, Geyer, and Connolly, who used to work for me at WHO, said that I was not quite right, in that when you have displacement of populations and crowding, you may have an epidemic of potential catastrophic consequences. So nothing is put in red, black, and white. And of course, I don't kind of like these blogs now because before, when they wrote letters to the editor for your article, it would be 6 months later before they were published, for example, by Lancet or New England Journal of Medicine, and it'd only be 2 or 3 people, and no one could remember the article. Now, I wrote this article in a British Medical Journal, and immediately they said, because I said one thing a few years ago, and now the old Noji and the new Noji, and the old Noji was better. And that's, and I was compared with Marie Antoinette. I still don't understand that comparison, the last one. Education, I can talk about that forever. Train the trainers, once again, since there's no career path. The person in charge of disasters internationally in the ministries of health and even state health departments are usually the newest, most inexperienced person, and he gets dumped emergencies as this person's response. But as they get promoted, they move out of that area. So you can train, train, train. We did a survey at WHO. 2 years later, not one of the persons we trained was still in charge of disaster response. These are issues which my colleagues will cover. Issues of accountability now. Money is getting tighter, and for some reason, the donors want to know how we're spending the money. Before they would say, here's $1 billion, go out and do good. Those were the good old days. Military involvement, once again, they have the lead role now. That's end of discussion. They have the lead role. In fact, this is an article, once again, by Truman Sharp, who is in the audience right here. I knew he was coming, and that's why I put this up, because I want a contract from him. But here once again, 1991. What have we learned since then? So the bottom line is we know what's wrong. Bottom line, what we need now are positive action in response to what we already know, not rhetoric, platitudes, and reciting the same old, same old. So thank you very much, and I'll be available for questions in the question and answer section of this event.
Okay, thank you very much, Dr. Noji. That was excellent. Dr. Noji and Dr. Burkle's presentations will be available also online. They already are. So if there are any of those citations or any of those other slides you want to get at, please go to our website, wilsoncenter.org, and click on the Global Health Initiative.
Thanks, Skip, and thanks, Eric. It's a pleasure to be here. I'm going to drill down in somewhat of a little bit different direction, but really a concept of a common thread that is beginning to emerge in the way in which we are looking at all disasters, but certainly large-scale natural disasters. Now, don't look at the print, but just focus on the figure itself. And this is in one of the articles we handed out to you. But what you need to know is that the large majority of natural disasters in the world today are handled very well by local resources, nation-state resources, and occasionally regional resources. If we look at mass casualty events, pretty much they are all taken care of locally and sometimes regionally. But most countries, developed and developing countries, have the resources for this. And so we look at disaster events, or sometimes called incidents, and again, they make up the large majority. But something happens in what we now call large-scale natural disasters, and the question is, what makes them large-scale, and why are they getting all this press? Why are they coming to everybody's attention, and are they occurring more often now than before? But if you look on the left-hand side, these are primarily ones that are geographically widespread, involve a large population, but usually a dense population, and are somewhat prolonged. And you see in the top, for the most part, the natural disasters are usually potential injury-creating events, like war and conflict and the possible chemical and nuclear radiation, but also large-scale natural disasters. But if indeed they are prolonged and they affect the public health infrastructure, we begin to see what we call not direct, but indirect consequences. And the interesting thing now is that in all of these situations, we don't monitor them very well because, for the most part, everybody leaves. The evaluation is over after the event, and we find out what the direct effects are. But over time, in all of those that on the left, there are more indirect mortality and morbidity than from the event itself. Potential illness-creating events, and we have outbreaks all the time. Matter of fact, WHO monitors about 35 cholera outbreaks every single week. But local resources take care of them very well. WHO teams and other resources are there, but we never hear about them. They don't become epidemics. They don't become pandemics. But in large-scale events, those on the right are what we primarily deal with. And large-scale natural disasters can, as the others, move into what we now call public health emergencies, which are primarily related to the indirect effects of these disasters. So modern-day public health emergencies are disasters that adversely impact the public health system and its protective infrastructure. So, we've always said in the humanitarian community that's water, sanitation, shelter, food, health, and also sometimes fuel. So the protective threshold is destroyed, as it is in war, often overwhelmed in many mega cities throughout the world, not recovered after war. One of the common things of all complex emergencies of the last 3 decades is that the public health and health systems were the first to be destroyed and the last to be recovered. So another reason to have these indirect consequences continued. Often not maintained, and certainly with the ethnic, religious, and other problems that we have in the world, often the public health systems and their protective infrastructure and whatever are often denied to certain groups. So public health emergencies can occur in any large-scale war and conflict, certainly natural disasters, and we'll talk a little bit about that. But, pretty much right now, if we have a pandemic, and certainly in many areas of the world, just an epidemic, they almost immediately become a public health emergency. And certainly we anticipate that in any deliberate kind of biological, chemical, or radiation disaster, that we would have one right away. This is, of course, from war and conflict, but it teaches us an awful lot about what we now know about large-scale natural disasters. So the blue line is the direct effects from violence, the deaths from violence. And even though it's very sexy, they get all the press, they are really over 10 to 14% of the total mortality. What really gets any attention at all are the beginning smoldering indirect deaths once the public health infrastructure begins to get destroyed. And it was a very, very small item in the Iraqi studies in October of 2004 when a Ministry of Health and Red Cross document said at that time that there were already more deaths from public health consequences than from violence. But the latter has continued to get all the attention. What we know is when the shooting is stopped and everybody leaves and no more attention, no more donors, but there is a decay function that lasts for the most part in all of these internal wars and many other large-scale natural disasters that lasts about a decade. And if you look at those indirect deaths during the conflict, about 71%, but the transition period after the shooting is stopped actually goes up and drops only to 45% over 4 years. And again, who are the victims? You can guess certainly women, children, and mental health are the most common problems that we have during that time. Most of these are related, both in war and in natural disasters, to access and availability, suicide, depression, alcohol, and drug rates, out of work males, IDP studies and camps in Croatia, Afghanistan, but also Katrina. Increase in gender-based violence. As a matter of fact, intimate partner rates is a great marker of community breakdown and economic and physical insecurity, seen in the Congo, seen in Iraq, seen in Katrina. And again, I'm just putting in examples, but it's quite common and consistent. Number of girls in school, because the economy has worsened in many places, certainly in the Middle East and Africa. They may have gone to school before, but they don't go to school any longer. They're now doing the work, especially in insecure environments, used to help support the family. And it's interesting because delayed enrollment also correlates with high child mortality rates. And again, the girls suffer more than others. And another interesting situation is the outbreak of really a re-emerging disease of dengue fever. But it was the economists. They never at all consulted with anyone in epidemiology or infectious disease, but they were looking for a marker of what they were seeing as urban decay in many areas, especially in Asia. And they came upon that the most sensitive marker of urban decay was dengue fever, because in governance, poor governance, and worsening economies, what traditionally governments did is to stop picking up the garbage. And so the styrofoam cups and the tin cans and everything just turned out to be great places for accumulation of water and vector for dengue fever. And so it's a very sensitive, the most sensitive indicator of urban decay, especially in Asian megacities and disaster-prone areas. So the common thread that I just talked about, we have begun to see in large-scale natural disasters. Another paper we gave to you was a study we did 1 year post-Katrina disaster. And this was data that came from the citizenry of New Orleans. The public health system and the surveillance system in New Orleans was totally destroyed. They had 3 physicians. One was left, and one we worked with. One had died of a heart attack during Katrina, and one committed suicide. But the entire surveillance system was on paper, and all of it was flooded out. I had absolutely no idea of any baseline data at all, no denominators, and as a matter of fact, no numerators looking for denominators because they didn't have the resources to do anything in the city at all. So it was the citizenry in New Orleans who began to find that there were more obituaries than the Times-Picayune, if you remember that paper during the height of Katrina. And so we went ahead and began to investigate this and found out that 1 year post-disaster, 47% increase in mortality over the baseline, and primarily related to the fact that the public health infrastructure and the system had deteriorated. And again, among the infrastructure were the fact that most of the psychiatrists had left. A charity hospital, if you have never been there, a large institution, one of the largest in the country, totally folded. It doesn't exist anymore. And no one was taking any surveillance. Matter of fact, the editorial comment with the article compared what had happened to New Orleans to the same kind of data that we were seeing post-conflict in Sierra Leone and Liberia. And the Indian Ocean tsunami, I mean, there's more money thrown at that still coming in, more money than any other disaster. As a matter of fact, comments made, we don't know what to do with it all. But if you read any of the Lancet articles about 2 years post-tsunami, large gaps in shelter, sanitation, potable water, health facilities, and a severe health worker crisis. So again, all related to what we put under the category of public health infrastructure and system. And the perfect storm that we're still witnessing, but again, right from the get-go. And again, it's what you start off with, but very poor baseline epidemiology, very high underage 5 mortality rate. Infant mortality rate, why is that important? Well, the infant mortality rate is just not, some pediatrician taking care of a neonate. Really, the infant mortality rate reflects governance and transportation and communication, education, so many things. And so it's why we tend to see it just in well-developed countries. But very high in Miramar, malnutrition rate, of course, high. But example of profound political repression, it has one of the worst corruption rates in the world, and unrepresented minority groups like the Karen, which of course just happen to have large pockets in the Irrawaddy Delta. And like Haiti and other places, expansive deforestation done in the Delta areas, so they took down the protective mangrove forestry and replaced it with shrimp farms and rice paddies. So with the climate changes that we've seen, the warming Indian Ocean, a soaring storm intensity, heavy rainfall, and a very low vertical wind shear that propelled the wind at low levels right across the delta, moved in about 25 miles, as you know, to about 25 feet. So everything sort of came together, and this is the kind of thing that we're seeing. So it's almost like a multidisciplinary kind of storm that occurs, and much of it is related to man's failure. So what we see in public health infrastructure and systems is we're seeing a rapid increase in the density of populations, overcrowding, so high density and large numbers of people in disaster-prone areas, about 78 million people per year. And some of our mega cities in Asia, They're increasing 1 million people every 6 months. Who are these people? Well, whether it's in Africa, which now about 67% of the population live in urban areas, or Asia, they are most often, I mean, if you look at what the classical person moving in there is a widowed or single woman with 3 to 5 children with no resources at all, but seeking resources and security by going to the city, which they often don't see. But these people are moving into disaster-prone areas where others would not move into. But they're moving in, and there's no public health infrastructure. China has realized this. China is actually building cities. I was in one and toured it, and it looked like a neutron bomb had hit it, but everything was there, drugstores and shopping centers and schools and apartments and everything, but no people. And then 6 months later, they moved many millions of people to this particular city. Why? Because they had to bring them someplace where they had public health infrastructure. Deficient dwellings, aged infrastructure. Our aquifers just in the area of Washington, D.C. and the East Coast were built in the 1800s and have never been repaired. Available infrastructure and capacity to respond in crises. We have it, but it can't rise to the capacity of many of these things, especially in potable water, again, and sanitation. And then what we know about in ecological and environmental changes. And one of the examples, I pushed the wrong ones here, here we go, is Haiti. You know, if we look at it health-wise, it looks like the United States did in the turn of the 1900s, except for the HIV/AIDS. But environmental degradation is high. And remember, in the same island as Dominican Republic, it's quite forested, but the forested areas are down now to about 2%. I mean, it's a real tragedy. So the same hurricanes that come through and get all the press that hit Florida, hit Haiti also. And yes, there are some deaths, like there is in Florida. But after it passes, so after the direct deaths, at least 3,000 in one of the last hurricanes of last year. There were about 3,000 deaths just from the flooding and the mudslides, okay? There's no root structure, like there's no root structure in Miramar to handle all this flooding. We don't know in the humanitarian community, really in the development community, is this a development disaster or an emergencies disaster or some combination of the two. But they are special, and quite honestly, we do not know how to manage them. Natural disasters and conflict, always an issue, and Eric touched on this, but generally disasters keep governments honest because they define the public health immediately. Remember, within minutes and hours of Katrina, I mean, we knew about the levees, we knew about this, okay? And they define the public health by exposing the inequities and the deficiencies. They always do, 100% of the time, okay? The way in which state and other sectors act in response to recovery really is largely predicated on how these kinds of political relationships existed before the crisis and are dependent on that. Disasters often hit those politically peripheral regions, as we call them, the disaster-prone areas, and can catalyze regional political tension. But there's often, those are populations that really do not have a say in the political process. Existing inequities can be exacerbated, certainly, by post-disaster governmental manipulation. And so the kind of response, the political response and everything, tends to unfold at multiple levels. How successful they are, quite honestly, to be successful to lead to change, I will have to say, is rare. Regimes, and just think about Miramar, and again, this was written certainly before that, and something we've known for a long time, are likely to interpret the spontaneous collective action, so think about Miramar, by NGOs as a threat and respond with repression. But what is interesting is the repression mimics exactly how they treat minority groups and have treated minority groups in the country for many decades. So in the aftermath, political leaders may actually regain or even enhance their popular legitimacy. And really, Myanmar, they did it amazingly. They had an election, didn't they, during that time to actually give them more power. So, I mean, something we really have never seen and wouldn't think about ourselves. Disaster diplomacy is a new term. I think it's come from globalization, sort of along with it. Because the reason is that with countries that we in the United States support with globalization, when a disaster hits, we're on the ground immediately because the mantra is if you can bring back the economy, then everything else will follow. As a matter of fact, the disasters of the future are that the same will happen in countries that we're economically interdependent with, and they will get super care and attention. But then we have other countries, if we think about the Pakistan earthquake that followed the tsunami, which was just saying, where is everybody, okay? Which is then dependent on OCHA and the Red Cross movement and the NGOs who are always striving and begging for money. The expectations, however, are out there, and the world feels one of the things that globalization was not prepared to look at, but that what globalization brought with it was the internet. So when the press moved from the tsunami to the Pakistan earthquake, I remember a scene on the top of a mountain that quite honestly hadn't changed since biblical times. But a reporter asked a tribal leader, had no teeth, was considered by most to be quite ignorant immediately when you saw this picture. And through an interpreter, the journalist said, well, what do you expect the world to do? And he said back again through the interpreter, well, we've seen on the internet what the world has given the tsunami, and we expect exactly the same thing. So at this high altitude, they probably had very, very good internet reception. So the expectation out there, quite honestly, that everybody's wondering about and battling is that the health expectations for disasters, quite honestly, through the world right now is quite equal. And yet that's not exactly true. The tsunami impacted over 12 countries, but many with internal or external conflicts. Diplomacy tends, however, to be maybe active at the edge of chaos, as they call it, which is sort of the narrow region where there's sufficient structure to hold and exchange information, but not necessarily where most of the problems are. So some disaster diplomacy is feasible, but rarely yields positive and lasting results. So, and coming last is I was asked to just comment on measures of effectiveness because that has been most of where my research has been, but we always talk about indicators like mortality rates and morbidity rates. Measures of effectiveness actually are the key indicators that if indeed you meet them, everything else really is, all the other indicators are the foundation for those things. So if you meet those, it's a good measure of improvement. So in a natural disaster, really it's how rapidly a health information system, the HIS, is mobilized in a timely and accurate way. And we do have NGOs who do only just set up health information systems. Also, how rapidly a surveillance system is restored, focusing on the 2 A's, access and availability of essential services, the health, shelter, water, sanitation. The key indicators that will define your vulnerable populations, and I'll talk briefly about that, but I think we know, and typically it's women, children, elderly, and disabled, but it can be different, okay? And ensure surveillance and services that are across all population cohorts. So it's simple. A lot of indicators support those things, but if those can be done, we kill each other trying to do other things, but the generalized universal measures of effectiveness for large-scale natural disasters would be those. I'm just giving 2 examples, simply because we may not use these kinds of indicators to determine vulnerabilities in other developing countries, but here they were for New Orleans. Those before under the poverty line, those with no access to a car or any transportation vehicle, And simply those over 65 and under 17 more likely to live in a household without access to a car. And transportation in our economy and everything is so important in order to get help. And those with chronic disease, those without medications, pregnant, those with no access to health care, on special diets. So vulnerability becomes various things depending on where you are and what country and other situations. But we have to have, and we have the capacity to determine these vulnerabilities before disaster, but unfortunately they are usually not done until after, and this was done after Katrina. So everybody's thinking about infrastructure, and everybody knows. But the one common thread that we have throughout the world is that we have not kept up with our infrastructure. And that's quite honestly what makes the difference between a large-scale disaster being something we can manage and something that we cannot. Thank you very much.
I think it's sort of special that I get to follow my two mentors, so I have to do well, and it's a little intimidating. What I'm going to talk to you about is more about recovery and the issues that happen in a disaster that impede recovery. And one of the things that I discovered in my career is that over time, and in places where political issues are a little sticky, the classification of displaced is really important. Are they internally displaced? Are they refugees? Are they what we called our Katrina evacuees? Or are they simply displaced? And the reason the classification is important is if you're overseas and you're a storm-displaced person and you cross a border, you're now a refugee. That means that your issues are now to be dealt with UNHCR versus the country of your origin. The same thing follows here. If we are displaced in our own country, we too are IDPs. But politically, it doesn't sound great to say, oh, by the way, we're the United States. We have 2.5 million people displaced from Hurricane Katrina, which, in fact, is 10% of the world's IDPs. That is not a really politically good thing to say in the middle of a disaster. By understanding what you are, you can also go back to the literature. There are different health effects for those that are refugees versus those that are IDPs. And by ignoring that body of literature means that you're not going to use your lessons learned. You're not going to know what to look for and how to recover. And again, also with knowing what you are, whether you're IDP or a refugee or evacuee, funding constraints are also determined by what you are. Again, UNHCR has the mandate for refugees. They don't for IDPs. But in the case of the U.S., if it's a disaster versus a catastrophe, determines how much money you have for recovery. And one of the things that we saw in the Katrina disaster was the Stafford effect, which in an emergency has a time-limited amount that you can use in order to help with recovery. So basic needs. Basic needs are the basic needs of life: food, shelter, clean water, healthcare, among others. And if you look at these, they're actually what are under social, economic, cultural rights in the Universal Declaration of Human Rights. In most disasters and in most of the disaster literature over the years, we've changed to that health and human rights model, which is more of an international type of response, a rights-based programming model. But simply supplying those basic needs help to improve mental health of those with resilience and take a whole chunk of people that may not do well and may not recover and help them move forward. And the resilience and mental health improvement means that they can realize their needs and can improve their current condition. So they're all tied together. And just so you know that I'm not making this up, if you look at the interagency standing guidelines, which came out in, I think, February of 2007, the base of that pyramid is basic services and security. So in other words, supply those basic needs, and a huge chunk of those people will not be as depressed or will recover quickly and move on and be productive. So let's take a look at an example. If you look at Katrina IDPs, and this is our own population in our own country, Shelter, security, and transportation were the most commonly reported problems. Remember, basic services and security. They, too, pointed out that we missed those basic needs. Average household salaries dropped from near poverty to poverty level. 16% reported not having enough clean drinking water, and only 13% boiled their waters, health, sanitation, food, and 47% reported significant dietary changes since the hurricane. Again, we missed somehow in getting those basic needs, and just so you know, this was a year after the hurricane, not at the height of the hurricane. Again, remember I said if you supply basic needs and you give them security, that mental health will improve. Well, when we did a survey of those Katrina trailer parks, 50% of respondents met criteria for major depressive disorder, 7 times the U.S. national rate. Reported suicides were 15 times the state's baseline rates, and suicide attempts were 79 times the baseline attempt rates. 50% of the respondents did not feel safe in their trailer or community, and more than 75% said that any form of counseling would be better. And they didn't just need psychiatrists and psychologists, social workers, religious leaders, any type of community support they could get. Now, Skip also touched on another issue that comes up. Women and children are usually the most vulnerable. There has been, at least in every hurricane that I reviewed, a suggestion and anecdotal evidence that there are increased calls to crisis centers, and particularly rape crisis centers, and increased reporting in emergency rooms and health clinics of women reporting violence. And sure enough, we decided that we wanted to document this for sure, and the lifetime rates of intimate partner violence in Katrina trailer parks of 25%, which was nearly triple the national rate. We redid this study 2 years later. This data has not come out yet, but it remains the same, which means that that gender-based violence issue is not going down, it's not getting better. It remains triple the yearly baseline rate in those areas. As Skip said, healthcare access is always an issue. In the middle of a natural disaster, public healthcare infrastructure can be destroyed. Even in the best societies, the public healthcare access can be destroyed. I think Katrina is an example of this. And that includes not just health clinics, but water and sanitation, health services, roads to be able to get ambulances to where you need to go, homes and food distribution. Again, all those sort of basic needs that you need to take care of. And if you look at healthcare access 2 years out from Katrina, 80% of respondents had at least one adult household with a chronic condition, 30% had a child with a chronic condition, and less than half of the respondents in the trailer parks, and we're talking 130 plus trailer parks in Mississippi, less than half had health insurance. And individuals with problems accessing prescription medications at the time, either they couldn't afford them or they couldn't find a healthcare provider to provide them, more or less because they didn't have a general healthcare provider and they were still relying on emergency rooms and urgent care clinics. So in conclusion, those planning and leading recovery efforts have to understand internationally displaced persons in a more global context. You can't just call them, quote, evacuees or displaced. Otherwise, you miss all the lessons learned and things that we know have happened in the past. And you tailor post-disaster recovery program to well-developed international models of rights-based care, paying attention to basic needs, understanding IASC guidelines for mental health, again, providing basic needs and security. And without adequate resources and access and availability to health care, internally displaced will not have the opportunity to help themselves, and they will develop long-term reliance on already stretched local and federal funding, as well as international funding if it's in a disaster that's protracted in an international area. Thank you.
Okay, well, thank you all very much for your presentations. They were excellent. As I said earlier, we're webcasting this, so just wait around for a microphone and let me know your question. Who wants to get started? One up here.
I'm Jane Henrici with the Institute for Women's Policy Research, and I wanted to know if you were continuing to follow morbidity rates in New Orleans. Specifically, I'm curious about New Orleans, but obviously the Gulf Coast in general post-Katrina, and that's for all of you. And then specifically, in addition, are you breaking down those morbidity rates now among women and different age groups? That is to say, women of different racial and ethnic categories and of different age groups. Thank you.
We actually looked at just the overall mortality rate in the last over 2 years past Katrina, and the rates were high, not as high as they were in the beginning, and they were sort of mid-level country rates. They weren't low, but they were still above what you would expect. And unfortunately, we did not break them down as per groups that were more vulnerable than others.
And the 47% increase in mortality, again, this is a crude number, but we are now in the throes of putting in requests, and there is some interest federally to fund it so that we can disaggregate those initial numbers and find out. If you disaggregate the mortality, morbidity rates, you'll find out just who is getting ill and who is dying. But we don't have that yet. But that's what we plan to do, and there is interest to continue this then for I think about a decade. So we're hoping that the money will come in and we can do it.
One up here.
I'm Allison Palzer with Population Action International. You mentioned, sorry, my brain just stopped working. You mentioned gender-based violence in post-disaster Katrina, but do you have numbers for gender-based violence in other nations, particularly international poverty populations, where they also have that gender violence problem?
We see that, I haven't done that natural disaster-wise, but certainly complex disaster-wide, and numbers are always elevated. It's hard to get population base rates for many of the countries where disasters are, but you do see upwards of 50%, 60% of women that admit to intimate partner violence.
Yeah, I agree, and that's why I did put in, the war-related, because I wanted you to see that. What's come to our surprise is that now that we're seeing more large-scale disasters, and we said, oh, it's curious, let's do gender-based violence studies on it, we're seeing the same thing. So it seems to be pretty universal when there's prolonged poverty and loss of infrastructure and the protection and things like that, jobs, livelihoods. So it seems to be universal to, whatever the initial event is probably important, but it seems like when it's that large, we get the same kind of response among the indirect issues, and gender-based violence may be the most sensitive community marker of that, of societal dysfunction and disruption. Yeah, I'll just give one other example. Everybody, we teach our students, who are the most vulnerable populations in complex emergencies, and oh yes, write down on the exam, women, children, elderly, and disabled. But like with the war in former Yugoslavia, as soon as the accords were signed, quite honestly, the most vulnerable population became the demobilized soldiers. So the Serb soldiers, the Serbs who were in Bosnia, Herzegovina, and Croatia, who were now forced to become refugees in Serbia. They hadn't lived in Serbia before, but they were in camps. A lot of people didn't realize that. Their children were not allowed to go to school. They couldn't get jobs. They still had their weapons. And they said, if things aren't going to improve, we're going to go back fighting again, okay? And we see that. We saw that in South America. We saw that in Africa. So it becomes a different vulnerable population. And they're also the ones who are going to, if there's a spouse there, they're going to have the results of that kind of depression and discontent. Well, we pay little attention to it. It was also the reason, for example, in Iraq, that we put so much effort to say the demobilized soldiers were the most important. We wanted to pay the salaries. Indeed, we had a program for that for a while, but that disappeared. And as soon as they were without jobs and without a future, they became the insurgents. So it's very predictable, very, very predictable across but it just changes in terms of who's the most vulnerable, depending on what phase you're in.
Okay, let's take a question right here.
This is a question for Dr. Lawry. I know that you started to get into the distinctions between, how we label people after a natural disaster, whether it's IDP or evacuee or refugee. And I know that a lot of the people who were evacuated from New Orleans to Texas and other states, felt like refugees more than anything else and felt discrimination. But can you elaborate a little more on why these distinctions are important as far as, whether it's the funding they receive or the time allocations, et cetera?
I think if we look at what happened in Katrina, we label them as evacuees. In fact, the press called them refugees, which of course was not correct. They went to another state. Now, arguably, some states you would consider yourself a refugee. If you're born and bred in one, the other one is. But you're actually an internally displaced person. I think evacuee was a very convenient term to use because if you consider yourself a, quote, evacuee, or if the politicians and the government and the media call you an evacuee, it means you evacuated and you're going back. And in fact, for many, this was not the case, and still the case, that they evacuated and they have nowhere to go, or they've completely resettled in another area of the country where they had not planned to do on their own. It's important if you look at it because we know that IDPs fare worse, mental health-wise, healthcare-wise, than refugees do. If you have to pick up and go to another country and you have to integrate within that system, perhaps healthcare is better, then that sort of holds true. In our case, with the IDPs, we have people who live in the first world who believe that it can all be fixed. And what we've come to realize is that it can't all be fixed. We still don't have a solution for those that are in travel trailer parks in Mississippi, Alabama, and in Louisiana. And so I think there was a huge problem with that because the mental health of these folks who couldn't repair what was lost and still can't, but yet still can't understand why that's not happening in our own country. And so it's a health issue to understand what you're labeled, but it's also a funding issue and a recovery issue for knowing how best to do that. And one of the strongest predictors of improving the health of internally displaced is actually housing.
Thank you.
Okay, Jackson, towards the back there.
Hi, I'm Steve Redding from Management Sciences for Health. And Dr. Lawry, you talked about the importance of meeting basic needs as the first response in a disaster, and one of the most effective. At the same time, Dr. Burkle talked about the importance of infrastructure and long-lasting infrastructure, and that being a factor in vulnerability of disaster-stricken populations. It seems to me it's a question of short-term versus long-term and how to make the transition. And there are a number of organizations who specialize in the short-term needs-meeting business of disaster response, and other organizations that specialize in long-term building of health systems that are sustainable. I was wondering if any of you had any thoughts on how effectively to make the transition, because in international public health, that's one of the toughest nuts to crack, is making that transition between disaster relief and long-term health system development.
I think that's for you.
I think it's for all of you.
Unfortunately, that was a $64,000 question. I see the problem as people saying, well, whose responsibility is it? Who funds what? And I see that as a problem. Certainly it was a problem in Iraq. And while some projects were getting a lot of attention, the public health system was falling apart right in front of them, and that has been seen before. I just don't think we have a system yet that well defines the process that we should approach these things. And so I've never been very comfortable with, the emergency side is mine and the sustainability side. And until that's settled and there's a better system that approaches this and better funding to approach it, I'm 68 years old now, and I thought by 40 all of this was going to be solved. And it's still not, so I don't know. I think it's the next generation's need to do it, but we're just not very good at it. And still, a big part of that also is, as soon as the shooting has stopped, let me tell you, people disappear. There's no more interest in donations, and so we talk about sustainability and moving into development, but it's just so slow that in that, what we say in Hawaii, that puka, that big spot in between, more infrastructure falls. And that's probably why, the indirect deaths actually increase up to 83% in that Central African study that I showed you during the time right after the shooting has stopped. And I think that's what happens also with the natural disasters. I mean, once it's over with, you just don't find the press, you don't find it, and everything is slow to do, and we have planners that come in, it's real slow, but they do, you really have to get that infrastructure back very, very quickly, and you have to sustain it. We just don't have, I don't think even our studies, the way we teach our next generation who are going to respond to this, we just teach them in that way. So I think your question is very important, and I'm embarrassed that my generation hasn't solved it. We should have.
A good example of where this lack of good transition. Let me step back. This one, once again, was identified by probably one of my heroes, the late Fred Cuny, 1984. Probably the best book that I've read in disasters. Very simple, and when I was teaching courses, I used it for introductory courses in disaster public health. It's called Disasters and Development by Fred Cuny, 1984. And he noticed that, particularly using some excellent case studies where, as Dr. Burkle said, a natural disaster leading to political change. One example would be the cyclone that hit Pakistan, or East Pakistan at that time, 1970. The response was so corrupt by the Pakistan government that it precipitated the civil war, possibly, and led to the formation of Bangladesh. Another good example is Nicaragua. The corrupt response to an earthquake by Somoza contributed to the rise of the Sandinista movement. So there's a lot. That's one issue. But this long-term process and where there's poor transition is after Hurricane Mitch in 1999. CDC, we were pretty well funded by USAID to put in epidemiology training programs in Honduras, El Salvador, Guatemala. These are countries which, in one disaster, 2 years of the health budget was wiped out by one disaster. We were there for 4 or 5 years with a whole new division at CDC created of international health. Once the funding stopped, the program stopped, basically. And even now, almost 10 years after Hurricane Mitch, the ministries of health still have not recovered. Even Hurricane Andrew in Florida and Louisiana, we're still doing these long-term studies of mental health, economic recovery. Still in Hurricane Andrew in Homestead area south of Miami, 40% unemployment among people who were impacted by Hurricane Andrew. With unemployed people, we also see a rise in spouse abuse. which has been noted many, many times. Well, here we are 16 years later, higher incidence of depression, suicide, the Armenia earthquake, 1988, other study that NIMH had funded. Now we're 20 years later, something like 25% of the people are still displaced. And it's we lose sight of these disasters when the cameras are gone, and already we're moving away from the disaster in China and Burma. But as Dr. Burkle said, now is when the greatest need, I think, is this recovery period and getting back into a development framework.
Anything to add on that, Lynn? No? Right across here in the white shirt.
Hi, Mary Lou Fisher, Samaritans First. Dr. Noji, you mentioned the floods in Iowa, and they're also in, as you know, Missouri and Wisconsin. That area being seen as the breadbasket and a place where there are very independent, self-sufficient people. Do you know if that's going to be studied in taking a look at how the local folks are going to be handling that? I know there weren't many deaths, but it's still a pretty big natural disaster. Could you comment on this, please? Anyone?
It's very interesting because I'm going to be giving a lecture on comparing the Great Flood of summer 1993, where Missouri, Iowa, Kansas, that whole area around Mississippi drainage area and Missouri River. And if you look at the whole Mississippi River drainage area, it's all the way from Washington State to western Pennsylvania. But the Iowa, we had, it's kind of a classic example. CDC, we work very closely with the Iowa Department of Health. In all 99 counties, we established electronic reporting, very unusual in 1993, with the reporting of the data electronically to Des Moines and then back to CDC. But you're right, it was when I compared the response and the community solidarity in particular in places like Davenport and Des Moines and St. Genevieve, and well into Missouri, it was pretty striking. But I haven't seen any long-term studies, but it was totally, it was much different than in the response to Katrina, that's for sure. And there are, if one looks at the studies from that flood, they're excellent. Mental health, implementation of electronic reporting, things which really hadn't been done before. But economically, it's the breadbasket, and I don't know if this is going to be true, but corn, I was watching CNN, and they were saying a significant part of the corn crop is gone. Well, with our fuel crisis right now, is this going to further impact on the gasoline prices, which everything is dependent on gasoline, and certainly healthcare infrastructure even. But you have a good question of the cultural background of a community, and is that, and there is a large literature on that in the social science area. Leah?
Yeah, right here.
Yeah, hi, Leo Bosner, retired FEMA. A question I'm thinking about here, all of you mentioned how some of these disasters have had really terrible severity, in part because of environmental degradation that had taken place. The logging went in, the trees got cut down, then terrible mudslides occur, and so many more thousands of people might die, or hundreds of people who would have been saved otherwise. A lot of this, I know, has been sort of ignored in the past by our public institutions and the governments, but now with a greater concern about global warming, and with the new administration coming in next year, do you see any opportunities where the public health leadership or some of the writers might start to weigh in trying to add a chip to the environmental movement and to the environmental degradation improvement to say, look, it's not just a matter of global warming or not just a matter of the polar bears, but if you can do some more things to stop the mudslides and stop the forests from washing into the rivers, you're going to cut down on a lot of your health and medical consequences of future disasters. I mean, I don't know how much of a difference that would make, but it seems like a lot of the yes, no, and the stuff is a matter of political will at the top. It's not a matter of technical skills of a clinician. Do you think that any health, you're going to start seeing public health or CDC articles pushing environmental issues as a way of mitigating future public health consequences of disasters?
Leo, where I've seen that, and it's very, very heartening, is the World Economic Forum, which, as you know, is the largest gathering of power, industrial, corporate sector, everyone from Bill Gates to you too is there, Angelina Jolie, et cetera. But the theme of last year was global warming. 2 years ago, last year was environment and energy security, and last year was the very first year where there were specific segments, modules on public health and public-private university partnerships, and the discussion of the private corporate sector working with the public health sector was going on simultaneously with the focus of the whole meeting on global warming and energy security. So I think the private sector is an area that is going to be one of the major driving forces in the next 10, 15 years.
I'd have to add that, institutional, just pick on one like WHO, which if you went there a decade or so ago, you'd just see essentially health providers. But all those organizations, certainly WHO as an example, is now they have social scientists and anthropologists and political scientists and all the rest. We haven't been that good about multidisciplinary approaches and even studies and writing, because we tend to focus in on our own journals and other things and giving speeches. But I think you're going to see a change in that with a more multidisciplinary approach to trying to solve the problems. I think somewhere down the line, we have to look. Well, a couple things have to happen. First off, public health has to be above politics. It isn't now, and I mean, we can find fault in the United States, in Myanmar and China and every other place. We just haven't looked at it, and we've been playing games with it. Public health has to be seen as a security issue worldwide, and it has to have its own international monitoring system. Because it does cross borders. The big experiment in doing that and testing out the limits of sovereignty of countries has been the international health regulations, the IHR, that has been around for a long time, but the latest IHR of 2005 that resulted from the SARS. And it's being tested every single day and whatever against sovereignty issues. But if that makes it, study it, because it's a big experiment in terms of, are we still focusing on countries, or do we really have a global focus, and can we make regulations? And public health has to have that same kind of issue. I mean, we're not going to handle a pandemic, for example, without a pretty solid public health infrastructure throughout the world. But we haven't graduated to that because we've been so nation-state-centric. But I think that's what these public health emergencies, whether they come from natural disasters or they come from internal conflict, is revealing to us, really. So I don't think we have a choice. That will be debated before too long, and that would be part of globalization. And I think the last issue on globalization, please understand, globalization has certainly benefited parts of the world like Asia, but those countries who have benefited the most economically from globalization also have the greatest discrepancies in terms of health. They have some of the worst situations, the worst indicators that we haven't seen since the 1950s. All right, so that's a real problem, and real debate of is it an economic issue or is health a human right issue? Big political issues that are going to come forward with that. So, that has to be addressed along with it, and that has to be a multidisciplinary approach, because right now the economists are looking at it just in an economic issue. And that's where a lot of that is in the disaster-prone areas that I talked about. So when there is a disaster there, you're going to certainly see a large population without this advantage. And with the privatization, there's less money going towards public health facilities, public hospitals, which is most common in those countries that we were just talking about. So they've been underfunded. So we're producing a real monster here. So we do need to have a global look at public health security. And then we'll bring all of these things, I think, under one umbrella, but we're just not there yet.
Right here, Kai.
Hi, my name is Colleen. I'm with Health and Human Services. My question is for all three speakers. What kind of work and or research is being conducted with regard to pre-disasters, such as disaster preparation and planning and risk management? Are you seeing the two fields kind of work together, or is it kind of split down, deal with the disaster and not much being done before an actual disaster occurs?
I can only speak for, actually, in terms of funding for research on disasters, it's magnitude greater now compared with prior to 9/11. Usually there's a spike in federal funding when there's a disaster, and agencies, if an earthquake, agency like U.S. Geological Service benefits. Hurricane, there's funding and goes boop for NOAA, National Weather Service. But 9/11 was just so traumatic that the infusion of, I don't know if it's still the case, but the budget for bioterrorism exceeded the budget for AIDS, malaria, and TB combined at CDC. Even though I was in the bioterrorism program and benefited from that, I had questions as to whether those priorities were. In retrospect, that led to a lot of funding of new staff, a doubling of the size of the Epidemic Intelligence Service program, and it was able to be focused on everyday problems like the current problems with the tomatoes and salmonella. But your question about research, I mean, National Institute of Mental Health, they've got a whole research division now on disasters. HRSA has a program on disasters. Hospital preparedness, surge capacity planning. The National Library of Medicine, they've established 7 centers of excellence in health information technology, second generation internet. They're working with Google, Intel, the Google Stanford initiative, and and of course doing funding of research in that area. So CDC, of course, National Institute of Allergy and Infectious Diseases, they have pretty robust program. Radiation emergencies, every type of disaster you can think of, natural disasters, technological disasters, radiation, transportation now, it's HHS is working with the Department of Transportation because of the fear of transmission disease in planes, and they're studying air currents in various types of commercial aircraft, and how's that, and they map where the passengers are, for example, bringing extreme resistant tuberculosis in, or pandemic influenza. So everything from a pandemic disaster, yes, so HHS, but the problem is coordinating all this, and there's a lot of duplication.
I think the question is interesting because most of the disaster research and disaster management has always been crisis management. So it's all lessons learned. It's never going back. And in fact, most times we don't even go back to the lessons learned. We start right back with the next disaster with the same problems we had previously. I think with the frightening media effects of avian influenza, the Katrina disaster, that was enough to sort of push us to say that we probably do need more research and more coordination pre-disaster so that we don't make the same mistakes that we do. And in fact, there is a Homeland Security Presidential Directive, HSPD 21, that was signed by the President that said that there will be a national center for disaster preparedness, et cetera. And if you look over the years, and I think Eric had the slide, the number of disaster centers and disaster preparedness and the amount of dollars coming from Congress to groups, academic groups, as well as other groups and universities to look at these issues has increased. And my only concern is that it may not be well coordinated. There are lots of centers out there, but none of them really talk to each other, and there's not a sort of concise voice of what they're doing, what they should be doing, and the places that they could do the things better than others. And so it's not, because there's a great number of tasks that need to be split up. It's not everybody should be doing the same thing. It's almost like the NGO community. You know, the NGO community finally, you know, semi-coordinates so that they don't do the same program in the same area of a country. It's the same thing with the disaster researchers and centers of excellence.
Even within one institution, Hopkins has 7 public health and medical federally funded programs. One program funded by the medical office in the Department of Homeland Security. They have another one funded by CDC. They have another one funded by HRSA. They have one funded by NIAID for emergency vaccination. The Johns Hopkins Applied Physics Laboratory has a humongous DoD grant for use of a lot of the DoD databases for TRICARE, for example, for pandemic surveillance. I know that the Department of Epidemiology at Hopkins has another grant from NIH working on the same thing, surveillance, but they don't talk with each other. Different sources of funding. One's from DARPA and I think TRICARE, and the other and Hopkins in Baltimore is funded by CDC. So when you ask me, is there research being done in public health? Yes. Another one, earmarks. Loma Linda University has a public health center of excellence, which is funded through TATRIC, Telemedicine Advanced Technology in Fort Detrick, which I never heard of, but does the same thing as CDC Centers of Excellence. But it came through a specific congressional earmark.
I would just simply round it out by saying no one does prevention very well, and it's not very popular, and it's never funded very well. But if you look at it, just bringing in the codes for building codes for earthquakes, the same earthquake strength can occur in San Francisco, and you get minimal deaths in some other place in the developing world, and you have thousands of deaths. It really does work. But the point also is that when it's done and it's very selective, it benefits the part of the world that probably is less apt to suffer those disasters. Certainly, the deep sea indicators for undersea earthquakes. We have them around Hawaii, but we don't have them in the Indian Ocean. And but it takes an event to sort of push it, but it's still not there. I think, though, the multidisciplinary approach to some of this will probably push more of the prevention aspects, but we are far short of it. Certainly in my career, we've always talked about prevention, but no one seems to fund it or work on it very much.
Okay, well, I don't see any other hands, and that's actually a good thing because we've pretty much run out of time. So I'd like to thank everyone again for coming, and thanks for 3 great presentations and so many good questions. And as I said earlier, you can find this online in about a week, and please feel free to send it to whoever you like, and we'll see you soon.